Vâng, Phiên báo cáo khoa học về phiên bài giảng về thần kinh của chiều hôm nay xin phép được bắt đầu. Thì trước hết chúng tôi xin mời báo cáo viên đầu tiên, giáo sư Francis Bolgert từ Cộng hòa Pháp. Thì giáo sư Francis Bolgert là một chuyên gia về hồi sức thần kinh, đã có nhiều năm làm việc trong cái chuyên ngành hồi sức và thần kinh học. Thì hôm nay giáo sư sẽ có bài báo cáo về hình ảnh viêm não. So we would like to start the session, and I would like to invite the first speaker, Professor Francis Bolgert, with the topic encephalitic imaging. So thank you. Please. You can start now. Okay.
Xin chào quý đồng nghiệp. Tất là một niềm vinh chu lũng đối với thời kỳ đuốc của mặt ở đại hôm nay. Mặc dù với tư cách là một bác sĩ nói thần kinh, tôi cảm thấy mình như một vị các hoàng linh vũ đại cuồng hút của điện quang thần kinh. Tôi rất vinh đủ được chia sẻ với các bạn một số suy nghĩ về vai trò của chân đoạn hình ảnh trong chân đoạn viêm não. Tôi đang mang tới vai trò quan trọng của MRI trong chân đoạn vai điều trị. So now I will carry on in English because otherwise it will be. I can also carry on in French, but I guess you prefer English. So encephalitis is an inflammation of the brain. It's a rare disease. It's about, for example, 7 encephalitis for 100,000 people for 1 year in the States. The encephalitis must be suspected on 2 symptoms: fever and acute or subacute central neurological syndrome. The problem is the symptoms are not very specific, and it can also be found in severe meningitis. And sometimes it's a mixture, because with encephalitis there is always a little part of meningitis, and sometimes, more rarely, meningitis can give encephalitis symptom. The symptoms are very common. It's headache, it's vigilance disorder from obnubilation to coma, and behavioral disorder. And this is very important because some encephalitis look like psychiatric disease. And of course, seizure, either partial or generalized, and focal seeing. And the causes are very numerous. It could be mainly infectious, either virus, mainly virus, bacteria, fungi, and parasite, and it could also be linked to autoimmune condition. Of course, the main thing to do is to make the history of the symptom and examination, but examination is sometimes rather poor. Lumbar puncture is, of course, very important. Usually there is a little meningitis, like viral meningitis, with pleocytose, with leukocyte not very high. It's about 50, and also proteinuria not very high, a little bit abnormal, but less than 1 gram per liter. It's exceptional to have contraindication to the lumbar puncture. CT scan is very often normal, so it's not really the good exam. And MRI is much more specific than CT scan, and with T1, T2 flare gadolinium. It can be normal, or it can be non-specific, but sometimes it gives very highly suggestive images of a pathogen. The MRI is the examination, the non-clinical examination that can be done on the quickest way, because exam, especially PCR for the viral, will not give result within a few days. So about etiology, this is a very important result of a big California encephalitis project, and which show that very often no cause is found. And when cause is found, it's mainly virus. Here you have the importance of virus among the different causes. And among virus, first, the family of herpes viridia, with at the beginning, of course, the first place, herpes simplex, HAZ-V1. It is the most common cause, and when not treated, the mortality is about 80% at least, and among the survivors, they have very severe sequelae and at least Korsakoff syndrome. Even when the patient is treated, this treatment must be given immediately, and the outcome depends clearly of the time within the acyclovir, which is a good therapy, is given. The lumbar puncture just could be important because it shows some red blood cell, and otherwise you wait for the PCR, but again, not immediately. So remember that if MRI is normal, it doesn't rule out the diagnosis. And on another way, if the PCR, the first PCR is negative, it doesn't rule out either the diagnosis, and you have got to do a new lumbar puncture 10 days later. And only if the second one is negative, then you can give up with this diagnosis. So this shows that if the time from to CT scan and or MRI after hospital admission is a big factor that makes the bad prognosis with this P, and the odds ratio is 8.4, which means it's very important. Anyway, even if the MRI is a real emergency, the doctor in charge of the patient must start acyclovir immediately, and even if it's expensive, it's much cheaper than not to do the treatment, and it's not a problem if you give acyclovir and it was not an herpes, no problem, because it's on the other way, it's terrible. So as you can see, this is the repartition. It can attack babies and otherwise all adults. So the intensity, okay, this is the typical way the encephalitis attack the brain in the temporal and frontal, very rarely occipital and parietal part. And of course the sagittal are the best way to see it. Most of the time it's bilateral, it's always bilateral nearly, but asymmetric. The HHV2 is, can give peripheral or pseudo-peripheral symptom on adults, and it can give meningoencephalitis only in neonates with very heavy lesion. So the HHV3 is the visit V, varicella persona, and the main manifestation is arteritis. It's not so frequent, and here are the pictures. The CMV is also one of the HHV5. It's mainly give ventricular diffusion. The HHV6 is a very frequent virus, and it can give encephalitis on children, but mainly on reactivation of immunocompromised patients. So as you can see, it can look like HV1. The HHV4, Epstein-Barr virus, it's of course the cause of infectious mononucleosis, and it's responsible for many associated with non-malignant and pre-malignant diseases. And in the neurological point of view, we can give the Alice in Wonderland syndrome, which is very special, very queer syndrome, and acute cerebellar. It's not exactly an encephalitis, but now it's suspected to be to play a huge role in the multiple sclerosis. There was a wonderful study that proved that recent EBV caused a 32-fold increase in the risk of developing multiple sclerosis. I know multiple sclerosis is rare in Asia, but in Asia you have myelin oligodendrocyte glycoprotein antibody, the MOGAD, and also the neuromyelite optica spectrum disorder, and it's possible that the Epstein-Barr virus could play a role in these diseases. And it's some people. There is not yet a vaccine against Epstein-Barr virus, but it's possible that if one day vaccination is available, and it could be possible then 10 or 20 or 30 years later, there will be very few or no more multiple sclerosis. So in others virus, so among the Flaviridae, there is a dung, the dengue is very frequent here. Very often it's asymptomatic or purely febrile, but it can give neurological complication, and especially at the second time, because when the patient get the dengue for the second time with a different serotype, in this category, then there is possible for severe form. So on this diapositive, you see the donut-like image, which has been described with the Japanese encephalitis, but it can also be found on with the dengue. So this one is the same family of virus, and it's only 1% of the patient will have encephalitis, but when the encephalitis is present, then it's very bad because of very high mortality of about 30%, and many neurological sequelae. It can affect thalamus, cerebrum, and also mainly the thalamus. And here is again the donut image here. And here is midbrain hyperintensity. So here is again this very special image. Rabies, just it's of course, no treatment. It's a different virus, and it can be. It's nearly always mortal, and the MRI is very important because there is no many way to do the diagnosis. The clinic can be misunderstood, and this is why the MRI have a big role. As you see, you have images, mainly frontal and temporal, with FLAIR image, and on T1 there is no abnormal signal, and also there is no signal with contrast enhancement. So it's important because the images are symmetrical, which is not the case in ADEM, and it could be sometimes difficult to make the difference between ADEM and rabies. So just a word about Mpox, because as you know, the director of the World Health Organization have decided that Mpox was a priority, and it's probably not so contagious as it was with COVID, because it's a contact-to-contact disease, and so we can hope that there will not be the same kind of epidemic. And, but anyway, Mpox can be responsible for encephalitis, but there are only 2 or 3 papers that have described it. So as you see, it's very asymmetrical. It was a Colombian young man, and also with spinal cord. And so you've also so among bacteria, many bacteria can give central complication, and mainly the Listeria. It's it's a germ that is resistant to 4 degrees. The refrigerator doesn't bother with the refrigerator, and the cephalosporin that is usually prescribed for meningitis doesn't work on Listeria, and so sorry. What is very special with Listeria is that it can give meningitis, which looks like viral meningitis, and it can give a subacute encephalitis or meningoencephalitis. And the main the main trouble with the Listeria, it gives a rhomboencephalitis. Of course, they can have abscess in the hemisphere, but mainly it's as you can see here. And here. And this was a 60-year-old woman that came to the emergency department, and she was fond of cheese, and Listeria love cheese, and with a soft skin like camembert, and probably that's what the reason she got it. Tuberculosis. Of course, it's mainly meningitis, but it can give complication. First, of course, the main for the clinician, the hypoglycemia is a very important clue to the diagnosis, and with a proteinuria which is high but less than 3 grams per liter, and with lymphocyte. And what is the main thing I would say for the diagnosis is the history of tuberculosis for the patient and for the family or the friend of the patient. This is very, very important. So the tuberculosis will give inflammation and narrowing of arteries, and of course inflammatory in the leptomeninge and citerne, and that the way it can give also blockade of the evacuation of the so here is the basal. Okay. Lyme, neurobrucellosis. Normally, it's a disease that is aggressive for the peripheric neural system, but it can give sometimes encephalitic syndrome. And it gives 2 signs which seem very nearly specific, which are those 2 signs. This is the round M sign here, like an M, and also the Tarsier sign, as here. And it seemed nearly specific of lying neuroborreliosis. So this is another disease in which the MRI can make the diagnosis. So neurosyphilis, usually the treponema goes very early in the story of the disease, and invade the nervous system rather quickly, and even at the first, and of course later. And this is a patient with, as you can see, you have also, as in many cases, temporal lesion.
Excuse me, time's up, so please wrap up. Time's out.
Okay, so Legionella, so it's it gives Rett syndrome. So anyway, the presentation, which is much larger, will be you can ask the secretary, and they will send you with a link if you just ask for it. So I just want to say a word about MDR, which is one of the autoimmune condition, which is probably the reason, autoimmune disease are the reason for the big amount of encephalitis with no cause. And probably among these no cause, there are many antibodies to discover. And the first one which has been discovered was the MDR antibody-related encephalitis by Dallnow, and he found out that many, especially many psychiatric symptoms, and those patients goes often emergency department of psychiatry, and if they have a seizure, it's a good thing in a way, because then they are referred to the neurologist, and Dallnow found that there were antibody linked to teratoma of ovary teratoma, because in these teratoma there are small pieces of brain which are of course recognized by the lymphocyte, and as normally there is no need for the tolerance for neural system, because the brain is protected, and so the lymphocyte and the immune system doesn't have to learn to avoid to make antibody against our own organ, not against the brain. And in this case, the lymphocyte found this product with this small brain, and then they began to make antibody, and the antibody, of course, goes into the brain and give encephalitis. And he found that just by giving a drug that could attack those antibodies, and you can cure the patient. And of course, after that, you've got to operate to get out of the teratoma. And now, after that, there is a big list of all these antibodies, that give different encephalitis, sometimes with just symptoms that cannot give the clue for the diagnosis. Sometimes they are very specific. And so this is the list of those, and with the clinical feature they can give, and some of them are linked to the to cancer, thymoma or lung cancer. What is very important is that those encephalitis respond to immune therapy, and it's mainly true for the antibody that attack the surface of the cell. When it's inside the cell, usually there is no so good results, but for the one that attack the surface of the cells, that make relationship with other cells and with receptor, and it make intervention with the circuitry of the brain, then you can have improvement of the therapy. And it's, for example, it's true for the seizure link to any kind of antibody, which are usually refractory to anti-epileptic medication and will respond to. Okay, so this is how the MRI play a crucial role in the diagnosis and in the treatment of the encephalitis.
Okay, thank you very much, Professor Bolgert, for a very comprehensive review on the imaging of the encephalitis.
Now I move